right, hello everyone, this is Dr. Pruett. Welcome back. Today we're going to be talking about geriatric emergencies and this very special population of our patients. I don't know if any of you have heard this term before, but there's something that's becoming more popular in public health circles called the Silver Tsunami. And this is the generation of the baby boomers who tend to be getting older. There's an increasing percentage of our population who are going to be over 65, and this is just projected to get bigger and bigger towards the year 2050. And then as our younger patients are not increasing at the same rate, it's not going to be long until we're overwhelmed with geriatrics. So this is a very important and timely lecture, as you are undoubtedly going to be faced with this population with your patient encounters. In fact, already almost 40% of the nationwide EMS calls for 911 service are patients who are older than 65. And so given that almost half of our emergencies involve this patient population, it's important to know some nuances with them and things to think about when you're interacting with them. They do have some very unique medical and psychosocial needs that need to be addressed during your patient encounter. Recognizing that the Silver Tsunami is coming, many emergency agencies and boards and coalitions have come together with different geriatric training programs for providers. And one of these is from the National Association of Emergency Medical Technicians, who is termed the GEMS Diamond. And this is ideally supposed to be an easy way for you to remember during your patient interaction with geriatric patients, things you should consider. So the G in GEM stands for geriatric, obviously. E is for environmental assessment. We'll talk about some of the things you should look at when you approach these patients, where they're living, where they're sitting, where they've fallen, things to look at and think about. M is for medical, which is obviously very important for us, and then social assessment as well. And all of things, environment, social, and medical, go into factors that may be contributing to your patient's overall health. And we're in a very unique position as pre-hospital providers, where you might be the only medical expert that gets to see this person in their living environment and then can help advocate for them. So it's important to remember these other psychosocial factors. When you're approaching their environment, I know you all do a very good job at this already and are, for the most part, very good advocates for your patients. I hear frequently about concerns about living conditions or caretakers, and I think that's wonderful, and you're taking your role very seriously as an advocate. But some of the things you really want to pay attention when you enter these patient environments: look at how sanitary it is, look at how safe it might be. Put yourself in maybe an unstable elderly person's shoes. Are there little dogs? Are there cords on the floor that they could trip over? Are there rugs that are bunched up? Do they have food in their refrigerator? Do they have family members that seem to care about them and are not seeming abusive or like they're taking advantage of the situation? How are their access to basic necessities? How can they take care of themselves? Can they even walk to the bathroom or to the shower? Those are very important questions and very important things to take in as you're noticing the patient's living conditions in the area where they live. Some questions that you can ask your patient: you might have heard of ADLs, or activities of daily living. This is a common medical term in the hospital and with physical therapists and occupational therapists who evaluate patients' ability to function. So are you having any trouble feeding yourself? Are you having any trouble swallowing? Do you have access to food? How do you bathe? Can you get to the shower? Can you get in and out of the bathtub? Can you get yourself dressed? Are you able to transfer from the bed to your walker, or from the bed to the toilet? Can you get to the toilet by yourself? Can you get to the toilet in time? Do you have any difficulty walking or moving around? All of these things can be assessed by physical or occupational therapy. And if there's any deficiencies noted, there is help available, but the patient first has to be recognized to have a problem. So these are very important questions that you can help ask while you're there on the scene doing your evaluation. It's also important to ask if they have any help. So sometimes elderly people are alone and are afraid to ask for help. Many times there's family members around or a very caring and involved neighbor, but sometimes people just don't have that support structure. And if they are experiencing some pretty bad medical problems that are debilitating for them, some insurance companies have ways to help. And so these are important questions to ask as well. If you don't think the patient is safe living on their own, try to figure out their support structure and work with them on how they can get help, or just notify the hospital when they get to the hospital that their living situation is probably not ideal if you have concerns. There's many psychological changes that come with aging. It's very difficult to have chronic medical illness. These patients are not stupid. They know they're probably close to the end of their life, and that can be very scary for many people. And as you get more and more illnesses that are compounded, you feel a little bit helpless and hopeless. There's physical limitations that come with that, whether it's arthritis or neuropathy or just not having much energy anymore. And then regarding social loss, if a lot of your friends are also elderly and are passing away, that can be a very big emotional burden for a lot of people. So not surprisingly, when you put yourself in their shoes, there's a very profound and I think unrecognized increase in depression and anxiety and agitation in our elderly population, because they are facing some very big psychosocial stressors, and not all of them have healthy ways of dealing with that. And if you look at the depression and suicide risk for adults that are greater than 65, particularly for males, the suicide rates per 100,000 by age start to skyrocket after 65. Not so much for females, but their rates of depression are still pretty high. Males are at increased risk for suicide, though. So make sure you're asking some of your depression questions and screening for that as well, because this is a very real problem with our elderly population, and I think it goes unrecognized very frequently. Along with the depression and the suicidality, of course, comes alcohol and drugs. And this is another very unrecognized, I think, epidemic among some of our elderly population, is the use of alcohol and the dependence on alcohol and drug abuse. This is one of the fastest growing healthcare problems for this population. It's important to remember while you're doing your patient assessment that they have normal changes that come with aging. So sometimes their vision might not be that bad and they need their glasses in order to be able to see whatever you're showing them or asking them. Also realize that they may need hearing aids. So if they seem difficult to interact with, make sure that you've given them every possible chance to have the best possible interaction with you. So ask them if they need their glasses, get their glasses. If they can't hear, get their hearing aids. And make sure you're addressing them and being as respectful as you possibly can. And I know we do a good job with this, but communication can be challenging. Just remember to be patient. Sometimes things move a little bit slower and there might be some communication barriers. So do your best to overcome those and address those and make the communication flow a little bit easier. It really goes a long way to establish trust. A lot of times, many of our elderly patients seem to be confused or altered, and it's really hard to tell if this is new and worsening or if this is old and they have some underlying dementia. So as you're assessing your patient, it's very important to talk to them first. I think it's very tempting to talk to the caretaker first because they probably can hear better and see better and typically have a little bit more information. But don't forget that your patient still might be able to see and hear and would prefer to talk to you first. And then if you're having difficulty understanding what the patient's saying or getting the history that you want, then you can involve the caretaker. Both the caretaker and the patient are going to be important parts of your patient history. But don't forget to acknowledge the patient first. Now, just a quick reminder, there are 5 causes of altered mental status. So as you're trying to troubleshoot what's going on with your patient, remember to think of medical things first and then keep your psychological reasons last. But number 1 is vital signs. So these are very important. They could be hypertensive, they could be hypoxic, they could be tachycardic, they could be infected. All of that can cause altered mental status. Toxic or metabolic, maybe we just talked about the alcohol abuse in this population, or possibly drugs. Maybe it's over medication, maybe it's under medication. Consider those things when you're evaluating your patient. Can it be a stroke? Can it be a heart attack? Very easily. What about ischemia or infection? Infection is very common. We'll talk about all of these things later, but make sure you're thinking about all of these in the back of your mind as you're doing your assessment. And lastly, before you just call this dementia and try to move on, psychiatric should be your very last consideration. After you've taken vital signs, consider toxic metabolic causes, maybe structural or ischemic or infectious causes. It's very important also just to try to establish baseline neurological function. If you're there with family or caretakers who know the patient a little bit better than you do, it's important to ask them what the patient normally behaves like. Can they normally walk on their own? Are they very talkative? Do they have any deficits at baseline? This is going to be very important information for the hospital when they're trying to figure out what's going on, and is this worse than normal or is this normal for this patient? So gather as much history about their functional status as you can before you leave. Just a quick reminder that vital signs are vital. Make sure you're getting a full set on every patient, and sometimes 2 sets. These are going to tell you a lot about what's going on with your patient. And in this population, over age 60, I have a very low threshold to get a 12-lead EKG for very minimal complaints. Elderly patients have very atypical cardiac symptoms, and I always have a high suspicion that the heart could be causing a lot of their issues. This is a very quick and very non-invasive test that's easy to get and can tell you a lot of information. So have a very low threshold to get a 12-lead on your elderly patients. And make sure you're taking time on scene, assuming your patient isn't critical, to get a good list of their medications and consider polypharmacy or medication errors or lack of compliance to be contributing to whatever's going on. So get a good list of their meds that's current if you can. If their meds are in a bag or a box by the kitchen, that's okay. Go through them, see what they're taking. It'll tell you a lot about their history. And then ask them if they've been taking them or been having issues taking them. Sometimes we talked about vision being poor. Sometimes patients have a hard time seeing the little tiny pills and knowing exactly what they're taking. So they're at risk for taking too many or also not taking enough. Infection is another very common problem in this population. Pneumonia, urinary tract infections, skin infections are the most common reasons for hospitalization in this population. Pneumonia being that if they're not able to swallow very effectively, if they've had an old stroke, or maybe they're just silently aspirating, that can lead to a pneumonia over days or weeks. Urinary tract infections, especially in your incontinent or chronically hospitalized patients, and also skin infections for patients who are non-mobile. So if you can, try to take a look. Usually this is sacral decubitus ulcers, but it can also be on the back of the heels or any pressure points where a patient who might be bedridden could have skin breakdown over a long period of time. Falls are one of the most common reasons that we get called to scenes. In fact, now that we've transitioned some of our more lower acuity medical calls to the ambulance service to respond, falls have become our number 1 call type, I just saw this month. And so the mortality associated with that is very, very high. It causes 7 deaths every hour in our country. And as the population ages and becomes more unsteady, this is just going to be an increasing problem. And it's a very dangerous problem for elderly patients. And some of the things that lead to that, one is just they're not as obviously spry as they used to be. But if you look at this healthy brain here on the left, it's nice and full with deep sulci and gyri. You can see good gray and white differentiation here in the cerebral cortex. Big area in this hippocampus here, that's where you have your memory. And if you look at an Alzheimer's patient here, the brain looks kind of shriveled with less gray-white. See how there's not as just much robust tissue there. The cortex has shrunken. There's deeper valleys here. The ventricles are much bigger and are taking up space. And this hippocampus, where your memory is much, much smaller. And so with the atrophy comes some loss of balance, some loss of memory, some loss of neurological function that can lead to increased risk for falling. Sometimes there's problems with peripheral nerves as well, so that leads to neuropathy, which is a tingling kind of pain, or sometimes just complete numbness, and it's very hard to walk if you can't feel your feet, and this is very common in our diabetic population. And so sometimes I've seen people that even have fractured their foot and not even realized it because they literally have no feeling in their feet or their ankles. And that leads to increased fall risk because they're not really sure where they're putting their feet, and then they can fall over. So there's decreased sensation, decreased mobility, there's decreased blood flow with increasing atherosclerosis, nerve damage potentially, and on top of that, as we get older, our joints tend to not have as much padding between the bones, and you can see an x-ray of arthritis here. On the left is a normal knee with some space in between the bone articulations there. And over here on the right is a knee with pretty bad arthritis. You can see the bone is touching bone in between, and most of the nice cartilage there in the middle has eroded away over time. And that's very painful, and it makes it hard to walk. And a lot of people compensate for the pain in one leg by placing awkward weight on the other leg, and that throws them off balance and again more prone to falling. As people age, the bones are more likely to break. I'm sure you've heard of osteoporosis before, but if you look at the trabeculae, the structure that makes up the bone, here's a healthy young back with nice sturdy bones, discs in between for padding between the bones so they're not rubbing on each other, and not too much air in between the space, right? But here's the elderly bone. As we get older, the bones can collapse, the discs get thinner, and the air in the trabeculae gets a little bit more, and the bone is kind of worn away, and that leads to increased risk for fractures. So even minor trauma, simple falls just from standing or tripping, can cause pretty serious injuries, including pretty bad fractures in this patient population. So have a low suspicion for fracture in any elderly trauma. It's very important to ask about recent falls. We talked about sometimes you'll get called for the fall and you'll find the patient actually lying on the floor. In that case, it's obvious that they fell, but sometimes if they're confused, ask them if they've fallen over the last couple days, because if they've injured their head, that might explain why they're confused. They can either be concussed or have a head bleed. It's very important to ask 2 questions, and I can pretty much guarantee you'll get asked these questions when the patient gets to the hospital. Was this a mechanical fall? Did they trip and fall over the dog or over a rug or over a stair? Or was this precipitated by a medical cause? Did they have a syncopal episode? Did they feel palpitations? Did they feel short of breath? Did they feel lightheaded? All of those things before they fell to the floor. That's a very important distinction to make, because it's going to dictate how you proceed with your evaluation. Another very important question is, are they anticoagulated? So are they taking blood thinners? This increases their risk for bleeding anywhere, but most importantly in the brain. So if they hit their head and they're anticoagulated, there's a very high risk that they could have bleeding or a hemorrhage in their brain. So the takeaway from this is that the chief complaint may not be the actual life threat. So let's say you get called to a fall and they're complaining of hip pain. Well, yes, their hip hurts, and there's a very good possibility that the hip may be fractured, but you also need to think about, why did they fall? Did they fall because they had a heart attack? Did they fall because they had a stroke? Did they fall because they had an irregular cardiac rhythm, or maybe they have an underlying infection? So always dig a little bit deeper with these patients and try to ask the question why a whole lot to really get a good understanding of what's going on. So be very careful. We mentioned the subdural hemorrhage earlier, just as a quick review. This is venous bleeding in the brain, the risk that the elderly population is at risk for. If you remember, we saw the atrophied brain next to the big healthy brain earlier. When the brain atrophies, it gets smaller, but the skull obviously doesn't get smaller. So there's more room in the skull for the brain to move around. And if they fall and hit their head, the thing that tears the easiest is the veins. And veins bleed slowly, but they do bleed, as you know, when you start IVs. And so over time, there's a fair amount of room, usually in an elderly brain, for the blood to accumulate. Usually over a couple of days, especially if they're on blood thinners, that blood doesn't stop because there's nothing to apply direct pressure until there gets to be too much blood in there. And by that time, the brain starts to be compressed by the excess bleeding, and that's a subdural hemorrhage. And so the highest risk populations we have are elderly, simply because they have more room in the brain for the blood to collect and more propensity for those veins to tear. Alcoholics also have accelerated tissue loss in their brain, so they're at increased risk for this as well, and then especially if they're on blood thinners. So the blood can accumulate slowly. That's why it's important to ask if they've fallen recently. Ask about recent worsening headache, any changes in mental status, or any changes in their neurological function, and have a high degree of suspicion for this if they've recently had a head injury. It's also very important, as we went over the osteoporosis and the changes in the bone, make sure you're strongly considering a cervical collar for any elderly patients that fall. When they hit their head, not only do they hit their head, but if their neck is forcefully extended, hyperextended, or flexed in such a way, it's also very prone to fracture. So make sure you're doing a good neurological exam, you're evaluating their mental status, and if they have any neck pain at all or neurological deficits, make sure you're placing that collar because they are at increased risk for C-spine injury as well. AFR is very lucky because we have a very active fall prevention program. Knowing that this population is more prone to falling, they are proactive in engaging the population about how to assess for fall risks and teaching them how to get up off the floor. And so if you see a patient who you think is a fall risk and could benefit from this, make sure you're doing your referrals to the heart team, because I think this is one of the most important programs that we have. And if these patients do fall, it leads to a lot of mortality for the patient, and it's also very costly for the health system. So if we can catch them early, it's very important. Another thing, I think we're pretty good here, but don't forget, please treat pain. So in this population, they might metabolize the pain medication a little bit slower. So don't stack meds too fast, but start with a low dose and then go a little bit higher if you need to. If it's minor to moderate pain, you can always start with Tylenol. You can consider ketamine in this population, but really my two options, if I think it's minor to moderate, I'll do Tylenol. If it's moderate to severe, I'll do fentanyl. Fentanyl is very easy on the blood pressure. It does not last that long, but it'll get them to the hospital. It'll keep them stable for you. And ketamine has, with the causes of, it might cause hypertension. I tend to like to use fentanyl in this population. Just make sure you're not using ibuprofen or NSAIDs in your patients over 65, because it can be tough on their kidneys or make them more prone to bleeding. This population is also more prone to cardiovascular disease if you look over time. Here's a young, healthy heart. Arteries are nice and patent, lots of room for blood flow, not too much atherosclerosis built up. But over time, as that heart has worked day in, day out for years and years and years, there starts to be cells that die just naturally. The heart gets a little bit scarred down and fibrotic. There's a little bit of sometimes increased muscle mass or even decreased muscle mass, and the heart is just not as effective as a pump as it used to be. And not only that, but the vessels tend to get filled up with cholesterol or calcium deposits as well, which all make blood flow a little less effective than it is when the patient was young. So knowing that with age, atherosclerosis is just a thing that happens to everybody, acute coronary syndrome might present differently in this population, especially your elderly diabetic females. Very strongly consider in any female diabetic patient who's presenting with just nausea and vomiting or epigastric pain that this could be cardiac. So again, we talked about earlier, have a low threshold to get a 12 lead and have a very high suspicion that the heart might be the cause of what's going on. Sometimes the symptoms for heart problems can be as simple as something like fatigue or lightheadedness or syncope. Sometimes shortness of breath is a little more obvious, but on those subtle review of systems, make sure that you're considering a 12 lead in the heart as the possible cause of the problems. Also, many patients in this age group complain of dizziness, which I find to be very difficult to work through sometimes clinically to exactly find out what's going on and what the problem is. And so make sure in your dizzy patients you're considering a stroke. I like to refer to it as the 5 Ds of posterior stroke. Your patient will be dizzy and dystaxic. Sometimes they have a hard time keeping their balance. Might have double vision, might have trouble speaking, might have trouble swallowing. And this is all because the posterior circulation blood flow feeds the cerebellum, and this is the main part of the brain that has to do with balance and speaking and kind of fine coordinated movement. It also happens to be the part of the brain that's most affected when somebody has been drinking too much alcohol. So in reality, your patient may look like they're drunk. They may have slurred speech, they may be off balance, they may be dizzy. and have double vision. That's because the same blood flow that could be causing a stroke in your elderly patient is the same area of the brain that's affected by alcohol. So just a quick way to remember that. Make sure if you have any suspicion of stroke at all that you're doing your Cincinnati and your LAMP scoring for ELVO. There are age-related skin changes, so the skin becomes thinner. What this means for your patient is they're more prone to ambient temperatures, either heat or cold, and that because the skin doesn't have as much adipose tissue or as robust of layering, there's going to be decreased healing because there's not as much blood flow to the surface. And so even the most minor skin tears can lead to infection. Bottom line, this is a very vulnerable population, and you're out there meeting these patients where they live in their environment, and you have an excellent position to be an advocate for them. And so, unfortunately, because this is a vulnerable population, they are at increasing risk for abuse. So making sure that you do a really good exam, look for bruises that can't be explained, burns, broken bones, unexplained withdrawal from activities. Make sure you have a low threshold to ask some of these questions about whether they feel safe at home. Do they trust the people that they live with? Do they look like they've been neglected? Are they covered in bed sores or maybe soiled undergarments that haven't been changed in a very long time? These are all important questions to ask. And if you identify any problems, you can either notify APD or New Mexico Aging and Long-Term Services. We do have a duty to report as first responders if you have any suspicions, and that's due to the Adult Protective Services Act. So make sure you're letting APS know if you have suspicions. It's okay to talk about end-of-life care. In fact, this is a very important question and will really help guide the hospital in what to do if there is a severe life-threatening emergency. So these patients in general recognize that they're elderly and they probably have thought about it, so it's not bad to broach the topic if you think it's appropriate and ask what their wishes would be if their heart was to stop beating or they were to stop breathing on their own, if they would want CPR or electricity or a breathing tube or a long ICU stay. There are different movements now, I think, that are gaining in popularity as patients want to take control over their end-of-life care. There's more and more hospice and palliative care available. The difference between these two is kind of subtle, and they do go together, but palliative services, just to give you an idea, can be started at any stage of a disease, and they can still be going on while the curative treatment is going on. So a patient, let's say, may have cancer, and it's a treatable cancer, but they'll still be on palliative care because it gives them extra access to care that is focused on their comfort. Now, as you get more towards the end stages of cancer, that's going to move more towards hospice, and this is recognized end-of-life care with a prognosis of less than 6 months. And usually by this time, the curative treatments have failed. So this is mainly focused on comfort as the patient is leading to death. So hospice lasts 6 months. Palliative can be at any point in the disease process. It's very important to ask about advanced directives as you're broaching this topic with your subject. They have something written down. If that's the case, it's signed by a physician, it's signed by the patient, that is bound in stone. The patient has been clear about what they want, and we need to honor that as EMS providers. If that is not readily available, then you can defer to the next of kin to be the decision maker, whether that's a spouse or children who knows what the patient would want in this situation. And sometimes there's medical power of attorneys that you can refer to that the patient had previously dedicated as their medical decision maker. If you have any questions about any of this, I know sometimes it gets complicated, so feel free to call the 7-8. They deal with a lot of these questions all the time, and there are some guidelines regarding end-of-life care and DNR in most orders as well. So that is all I have for you today. If you have any questions, please feel free to reach out. Thank you.